Many of the structures, process, and practices for UK medical regulation and healthcare delivery make more sense when you know the background to the initiatives which brought them into effect. When the NHS was conceived in 1948, it was based on the principles of unity and cooperation. There were no real organisational distinctions between bodies responsible for financial control and those providing services. It was all just simply the NHS. By the late 1980s, prevalent social attitudes had changed. The Conservative government of the time, led by Margaret Thatcher, had long been working to reduce the financial burden on the UK taxpayer for provision of public services, and now turned its attention to the NHS. It sought to eradicate inefficiency, reduce costs, and improve service through adoption of a business customer management approach. The NHS and Community Care Act of 1990 arose from this business thinking approach, introducing what was referred to as the internal market to the NHS. In this model, a health authority became a purchaser and managed its own budget, while hospitals and other organisations who deliver services became providers. Purchasers were now effectively selecting where to buy care and services from a choice of providers. Having options, they may purchase one service from one provider and another elsewhere. The idea was that financial transaction and competition between providers would reduce costs, drive efficiency, and improve quality of services. To become a recognised provider, organisations became NHS trusts, independent bodies, each with their own individual management structures. Doctors, nurses, and managers were employed by the trust itself rather than directly by the NHS. The trust could in turn contract services such as cleaning, catering, and building maintenance from other external organisations. Following a change in government to Labour during the 1990s, devolution within the UK led to the creation of the Scottish Government, Welsh Government, and Northern Ireland Assembly. Significant powers, including control of healthcare, were passed to the administrations of the relevant nations which make up the United Kingdom. From this point onward, the development of healthcare provision in the four corners of the UK began to diverge significantly. By 2010, both Scotland and Wales had moved away from the internal market approach for the NHS, creating new systems where hospitals and decision makers all worked collaboratively. However, both England and Northern Ireland continued with the purchaser-provider model, implementing a series of extensive and costly restructures along the way in search for success. Over time, there grew a consensus that these restructures had been counterproductive and that the internal market concept was causing more difficulties than it solved. So in 2022, the Health and Care Act initiated the latest restructure for NHS England, including legislation enabling the fundamental shift away from competition with a new expectation of collaboration between providers. We generally talk about the NHS as if it were one consistent and coherent organisation, but the structures and arrangements differ significantly across the UK. This series of videos includes separate tutorials dedicated to the structure and direction of the NHS in each of the four home nations. Throughout the years, healthcare was beset by a number of high-profile scandals. In 2001, an inquiry into events at Bristol Royal Infirmary concluded that substandard care had directly led to the deaths of dozens of children. Then came the case of Harold Shipman, a GP who was convicted of 15 murders but believed to have killed as many as 218 elderly patients for personal gain. In an effort to both maintain high standards and bolster public confidence, the process of revalidation for a doctor's license to practice was phased in from 2012. A similar process for nurses began its rollout from 2016. In 2009, came revelations that poor standards of care, neglect, and even bullying of patients had been allowed to persist unchecked for several years at Stafford Hospital. The public inquiry into these events was led by Robert Francis QC. The findings of the inquiry are detailed in a document currently referred to as the Francis Report. It concluded the Mid-Staffordshire NHS Foundation Trust had been prioritising financial performance and government targets over and above patient care. The final report focused on the following key recommendations: a structure of fundamental standards and measure of compliance, openness, transparency, and candour throughout the system underpinned by statute, improved support for compassionate, caring, and committed nursing, stronger healthcare leadership, development and sharing of accurate, useful, and relevant information. These principles have fed into the development of the current regulatory system for UK healthcare and our modern concept of what it means to be a good doctor.